Good evening, everyone. This is Module 2 of AHIP training. We're going to go ahead and get started. I'm not going to wait any longer because we are recording, and should someone wish to see the entire session, they can watch the recording. So I want to go ahead and share my screen so we can get started. I had this brilliant idea last night, and I don't know if it's going to work. And I'll ask you what you think, because when I finished with going through the module 1, I did the practice test and got 100. And then it occurred to me, perhaps you might want to see me do, or you might want to answer the questions in the practice test to see how much you have retained. So depending on the time that it takes us to go through module 2, when I get to that point, rather than leave you on your own to do the practice test, perhaps we'll do it together. What do you think about that? Do you think it's something that you might want to stick around to do if it's not too late, or you'd rather do it later? You can put a 1 in the chat, or if you want to do it now, if we don't run over too late, and a 2 if you think, nah, you'd just rather do it later. 1 or 2 in the chat, and that will let me know what you're thinking. Okay, looks like most of you think it's a good idea. Well, for once I had a great idea. I'm happy. Okay, so you will see now I'm back on the AHIP site, and module 1 is already checked off because I've completed module 1. Now we're going to go into module 2. Now remember, I may not go through a lot of put this someplace, of the information at the beginning of each module because it is consistent. It is the same. In module 2, we're talking about Medicare health plans. So this is where you're going to be able to explain that under the Medicare Advantage program, private companies offer health plans that cover all Medicare Part A and B benefits. You'll understand who's eligible to enroll in a Medicare Advantage plan and the possible premiums that may be entailed. You'll be able to identify the different Medicare Advantage plan types: coordinated care plans, private fee-for-service plans, and medical savings account plans. You'll learn about special needs plans, the various types of special needs plans, and who can enroll in them. You'll also explore the various types of coordinated plans that include HMOs with point of service, POS options, and PPOs. You'll gain an understanding of MSA plans, including what they do and do not cover. And of course, the MSAs are the medical savings plans. You learn about the types of coverage that employers and unions may offer their retirees and their dependents. You'll be able to discuss the Medicare rules that apply to individuals who are still working beyond retirement age at both large and small employers. You'll understand that individuals who qualify for Medicare and Medicaid are considered dual. You will also know how the Medicare Advantage enrollees may obtain prescription drug coverage through coordinated MAPD plans or those who enrolled in Medicare savings plans. They can have standalone prescription drug plans. You'll also review other types of Medicare plans which are not Part C, including Medicare cost plans, PACE plans, and Medicare, Medicaid plans. You'll identify the protections afforded to everyone. And of course, the last piece of every segment is about appeals processes and grievances. So to complete module 2, we need to go through the training. And of course, I will mute. Okay, so now you'll hear me talking. The instructions on how to navigate are the same for each module. You have the previous, the next. Click on the icon button to collapse the table of contents. You can stop the audio by clicking on the bottom on the button. And you can also download the slides. Remember, over in the left-hand corner of each module up at the top, you can download the slides for each module. The conditions, terms and conditions are always going to be the same. Everything here is copyrighted, of course. It does not belong to us. The training program is intended to provide guidance only in identifying factors for consideration in the basic rules and regulations. Now, I am told by some people that I cannot go beyond where she is speaking. If she doesn't talk through, that I won't be able to use the next button. So let's see. Well, it works, so we'll go on. In this course, the learning objectives is to explain what types of Medicare health plans are available, who's eligible, describe the different types of special needs plans, describe the features of different health plans, describe the different types of benefits offered by Medicare Advantage plans, and explain how Medicare health plans work with prescription drugs. This is our roadmap. We will do Medicare Advantage plans, we'll do MA plan types, coordinated care plans, special needs plans, MA plan types, private fee for service, Medicare savings account plans, Medicare Advantage employer union plans, Medicare Advantage eligibility, cost and benefits, Medicare Advantage and prescription drugs, other types of Medicare health plans, and enrollee protections, appeals, and grievances. I can't start to mess up words because we're just at the beginning of this. I have 3 more days after this. So Medicare Advantage plans. Let's talk about Medicare Advantage plans. As we learned in the first module, Part C is Medicare Advantage plans. An overview of the Medicare Advantage plans known as Medicare Part C. Private companies offer health plans that cover all of the benefits of Medicare Part A and Medicare Part B. Many also cover Part D prescription drug plans. So those are called MAPD plans. All Medicare Advantage plans have a maximum out of pocket for basic benefits. Many Medicare Advantage plans also offer additional benefits that Medicare does not cover. The types of Medicare Advantage plans are coordinated care plans. These are plans that have a network of preferred providers and include HMOs. Some HMOs have a point of service benefit that allows beneficiaries to go out of network subject to limitations, and PPOs, which are preferred provider organizations, which can be either local PPOs or regional PPOs. Private fee for service plans and medical savings account plans. So we got those 4 plans. Everybody got that? Let's look at HMOs. HMOs are generally only cover services furnished by doctors and hospitals within the plan's network. There are certain exceptions. Emergency services provided by out-of-network providers, emergency services, when the enrollee is temporarily absent from the planned service area, dialysis services are covered outside of network. Urgently needed services furnished by out-of-network providers are covered when the enrollee is temporarily outside of the service area or in rare circumstances when the network is not available. If a needed specialist or a covered procedure is not available through participating providers, the HMO plan will authorize out-of-network services. So the individual can't just choose to be out of network, has to be an emergency. They have to be temporarily outside of the network when they get sick to get urgent care, or there is no provider within the network that can provide the services, then the plan actually will authorize out-of-network services. HMO enrollees may be required to select a primary care provider from whom they receive their day-to-day outpatient care. HMO enrollees are required to obtain a referral from their primary care for specialist services. Some HMOs offer a point of service option that allows enrollees to go outside of the network without receiving prior approval. Unlike a PPO, an HMO POS plan may limit the services available out of network or may put a dollar cap on the amount of out of network coverage. Cost sharing is generally higher for services provided by out of network providers. Second type, PPOs. You can get care from a provider in the United States who accepts Medicare and the plan. They're not limited to network providers. Usually, higher copays or cost sharing is necessary if the services are from an out of network provider. You do not need a referral or authorization to see an out of network provider or receive an out of network service, but the patient is encouraged to contact the plan to be sure that the service they wish to obtain out of network is medically necessary and will be covered. With the PPO plan, they may be required to get a referral or authorization to obtain certain in-network services or see certain in-network providers. But if they fail to do so, covered services will still be paid by the plan. They just have to pay the outer network higher cost sharing. Regional plans, PPOs, that are offered are generally for a whole region, and that region most oftenly is the state, or it could be several states. Special needs plans, SNPs. Special needs plans are a type of Medicare Advantage coordinated plan, can be an HMO or a PPO, specifically designed to serve a targeted subset of Medicare beneficiaries. So, in addition to meeting all Medicare eligibility criteria, beneficiaries must also meet criteria specific to the type of SNP plan in which they wish to enroll. All SNPs must implement an evidence-based model of care with appropriate networks of providers and specialists designed to meet the specialized needs of the plan's targeted enrollees. All SNP plans include prescription drugs. Remember that. That's usually on the test. All SNPs include prescription drug plans. So let's look at those special need plans. The first one is the C-SNP. That's for chronic. Chronic conditions, SNPs, are the SNPs that restrict enrollment with certain chronic or disabling chronic conditions specified in CMS regulations. Note that every chronic plan doesn't cover the same chronic conditions. Each carrier has different plans for different chronic conditions. Those conditions include, but are not limited to, diabetes, stroke, certain cardiovascular disorders, cancer, chronic lung disorders, HIV, dementia, chronic kidney disease, certain mental health disorder, drug or alcohol dependency, or neurological disorders like epilepsy or Parkinson's. CSIPs may focus on one severe chronic condition or on a grouping specified by CMS of severe or disabling chronic conditions that represent multiple commonly comorbid and clinically linked conditions. Each CSNP will specify the condition or conditions necessary to enroll. The next one is I-SNPs, institutional SNPs. Those are the ones that restrict enrollment to Medicare Advantage eligible individuals who, for 90 days or longer, have had or are expected to need the level of services provided in a skilled nursing facility, a nursing facility as defined under Medicaid law, an intermediate care facility for the individuals with intellectual and developmental disabilities, a long-term care hospital, an inpatient psychiatric facility, or certain other facilities specified by CMS. Institutional equivalent SNPs enroll Medicare Advantage eligible individuals who live in the community but require an institutional level of care, such as they're determined by an impartial entity to need the level of services furnished by the types of facilities listed above. Eligibility for an institutional equivalent SNP may be limited to certain assisted living facilities. So you have C-SNP, you have I-SNPs, and you have D-SNPs. The dual eligible SNP enrolls certain categories as determined by each state of individuals who are eligible for both Medicare and Medicaid. Dual eligible beneficiaries include beneficiaries enrolled in Medicare Part A and or Part B and receiving full Medicaid benefits or Medicaid assistance with Medicare premiums or cost sharing. The categories of dual eligibles include QMB, qualified Medicare beneficiary. Medicaid helps pay premiums, deductibles, coinsurance, copays for Part A, Part B, or both programs for these beneficiaries. SLIMB, specified low-income Medicare beneficiaries. Medicaid helps pay Part B premium for these individuals. QIs, qualified individuals, Medicaid helps pay Part B premium for these people. Qualified disabled working individuals, QDWIs, Medicaid pays the Part A premium for certain people under 65 with disabilities who return to work. Medicaid may also cover medical costs that Medicare doesn't cover or partially cover. For example, nursing home, personal care, and home and community-based services. Beneficiaries' coverage can vary by state. Dual eligible individuals may also be eligible for full Medicaid. Such individuals are known as FBDEs or QMB plus. Full dual is an B, D, E, or QMB plus. Types of D-SNPs. There are different types of D-SNPs, including fully integrated dual eligible, FIDE, highly integrated, HIDE, and coordination only, D-SNPs. The FIDE SNPs provide full benefit dual eligible individuals with access to Medicare and Medicaid under a single organization that has both a Medicare Advantage and a Medicaid managed care contract. FIDE SNP membership is limited to individuals who receive their Medicaid benefits through the organization or a parent or affiliate of the organization. FDE SNPs cover primary care, acute care, Medicare cost savings, long-term services, and supports LTSS. I'm not sure what that is, but LTSS, including coverage of nursing facility services for a period of at least 180 days during the plan year. It also covers behavioral health services, home health services, medical supplies, equipment, and appliances. FIDE SNPs coordinate the delivery of covered Medicare and Medicaid services using aligned care management and specialty care networks. FIDE SNPs also coordinate or integrate beneficiary communication materials, enrollment, communications, grievance and appeals, and quality improvement. All FIDE SNPs qualify as applicable integrated plans, but not all applicable integrated plans are FIDE SNPs. So all FIDE SNPs qualify as applicable integrated plans, but not all applicable integrated plans are FIDE plans. Let's talk about the HIDE plan. The FIDE and the HIDE this year are the two terms that have been driving me up the wall. I'll be honest with you. It seems once I get one set in my mind, then the other confuses me. So perhaps going through this with you will help me to understand it as well. HIDE SNPs cover certain Medicaid benefits under a capitated contract between the state Medicaid agency and the Medicare Advantage organization. The Medicare Advantage organization's parent organization or an affiliate of the MAO or certain local nonprofit but public benefit corporations that have a founding member that is the MAO. The MAO's parent organization or another entity that is owned and controlled by its parent organization. I just had something pop up on my screen. I need to get it away. The HIDE SNPs cover all Medicare benefits, and to the extent enrollees are eligible for these benefits, community long-term services and support, including some days of coverage of nursing facility services during the plan year, or behavioral health services are included. HIDE SNPs may also qualify as applicable integrated plans if they meet the relevant conditions. Coordination only D-SNPs are D-SNPs that do not qualify as HIDE or FIDE. Coordination only D-SNPs have a CMS approved contract with the state Medicaid agency that stipulates to coordinate Medicare and Medicaid covered services between settings of care. The D-SNP notifies or arranges for another entity or entities to notify the state Medicaid agency, individuals or entities designed by the state Medicaid agency or both of hospital and skilled nursing facility admissions for at least one group of high risk, full benefit, dual eligible individuals identified by the state Medicaid agency. If the coordination only DSNP only enrolls partial benefit only dual eligibles per the terms of the contract with the state, it is not required to meet notification requirement when the Medicare Advantage organization also offers an integrated DSNP with enrollment limited to the full benefit dual eligible individuals that is in the same state and service area. Applicable integrated plans are certain DSNPs and entities with a Medicaid managed care organization contract with the state that work together to coordinate Medicare and Medicaid benefits furnished to the full benefit dual eligible enrollees. Applicable integrated plans include, but are not limited to, all FIDE SNPs, hide SNPs that under state policy may only enroll full benefit dual eligible individual whose Medicaid benefits are covered under an MCO contract with the state, and either the Medicare Advantage organization offering the DSNP, the DSNP's parent organization, or another entity that is owned and controlled by the DSNP's parent organization. Applicable integrated plans are required to have unified appeals and grievances processed. Private fee-for-service. Some areas have private fee-for-services plans. Those are Medicare Advantage plans as well. Excuse me. Individuals enrolled in private fee-for-service plans may receive covered services from any provider in the United States who's eligible to provide Medicare services and agrees to accept the plan's terms and conditions of payments. They're not limited to receiving services from a network of plan providers. So unlike HMO and PPO, they can be contracted, but they don't have to be contracted. Some private fee-for-service plans contract with providers. If the private fee-for-service plan has a network, then enrollees may pay more if they see providers that are not in the network. Except for emergencies, enrollees must inform providers before receiving services that they have a private fee-for-service plan so that if the provider doesn't decide to accept the plan's terms and conditions, they both know up front. Non-network providers that accept original Medicare may choose not to accept the private fee-for-service plan. Therefore, an enrollee needs to confirm that the provider of their choice will accept the plan before enrolling in the plan. Non-network providers are prohibited from charging a private fee-for-service enrollee more than the cost sharing specified in the private fee-for-services plans, terms, and condition. Cost sharing for out-of-network services may include balance billing up to 15% of the Medicare rate only if allowed in the plan's terms and conditions. Balance billing happening when a doctor is eligible to accept Medicare, but is not a Medicare participating provider under original Medicare. Under original Medicare, these non-participating providers are allowed to balance bill 15% over the Medicare payment amount. Private fee-for-service plans may choose whether or not to allow non-participating providers to balance bill their members. Private fee-for-service plans may choose to offer Part D plans, but are not required to do so. Now, in this area, it didn't tell you though, but with the private fee-for-service plan, if the plan does not have a Part D prescription drug, that's the only Medicare Advantage plan that you can add a Part D. Medical savings account. A Medicare savings account is a high deductible Medicare Advantage plan combined with a special medical savings account. Medicare contributes money to the beneficiary's medical savings account to assist with paying for Medicare covered services during the deductible phase. The amount of the contribution varies by plan. Money left in the account at the end of the year stays there. If the beneficiary remains enrolled in the plan the following year, Medicare will add any new deposits. If a Medicare savings account enrollee uses all the funds in their medical savings account, they must pay out of pocket until they reach their deductible. After the deductible is met, the plan pays 100% for covered services. The maximum allowable deductible for Medicare savings plans in 2025 is $16,350. However, most Medicare savings account will have a substantially lower deductible. There is no premium for a Medicare savings account. Medicare savings plans cover Part A and Part B benefits, so the beneficiary must continue to pay their Part B premium. Medicare savings account do not cover Part D Medicare prescription drug benefits. So this is another Medicare Advantage type plan where the individual can have a standalone prescription drug plan. Medicare savings account enrollees may receive covered services from any Medicare approved provider in the United States if the provider chooses to accept their plan. Medicare savings accounts may not have a network or may have a full or partial network of providers. All non-network providers must accept the same amount that original Medicare would pay them as payment in full. This is the amount the enrollee will pay the provider before the deductible is met. An example of a Medicare savings account. Mr. Johnson recently enrolled in a Medicare savings account from Original Medicare. He was surprised to receive a statement from the plan indicating he had financial responsibility for the screening colonoscopy services he received 2 weeks prior. He called the plan and said he was confused because most preventive benefits have zero cost sharing under Original Medicare. The plan explained that under a Medicare savings account, beneficiaries must pay out of pocket for even preventive care services if they have not reached the annual deductible. Union plans. Employers and union may offer their retirees and their dependents Medicare Advantage individual plans. Medicare Advantage plans are not only available to individuals based on their employer, known as employer waiver plans or EGWPs. A Medicare Advantage plan offered through a direct contract between the employer or union and CMS is known as a direct contract plan. Employers with less than 20 employees may be able to offer Medicare Advantage plans to their active employees and dependents. Any size employer can offer Medicare Advantage plan to its retirees and their dependents. Employer group waiver plans and direct contract plans are different from other Medicare Advantage plans because eligibility to enroll is limited to certain active employees, retirees, and their dependents, and because a variety of regulatory requirements are waived as they apply for the plans. Eligibility for those plans to be eligible to enroll in a Medicare Advantage plan, a beneficiary must be entitled to Part A and enrolled in Part B. The beneficiary must permanently live in the Medicare Advantage service area. If the beneficiary spends 6 months or more outside the plan service area, they should only enroll in a Medicare Advantage plan with a visitor or traveler benefit. The individual must be a United States citizen or lawfully present in the United States on or before the enrollment effective date. The Medicare Advantage plan must generally enroll any eligible beneficiary who applies regardless of health status. Special needs plans only enroll beneficiaries within their targeted population. Employer group waiver plans or direct contract plans may only enroll Medicare beneficiaries who are active employees or retirees of the employer or union that's offering the plan. A beneficiary's enrollment in an employer group waiver plan must be based on receiving employment-based health coverage from an employer union health plan sponsor. Coverage obtained through a professional or another group association would not make a beneficiary eligible for an EGWP, except to the extent that the coverage obtained through the association can properly be characterized as employment-based group health coverage. Some examples of group health coverage would be an association of employers, such as a school board, may offer its former employees a plan. A professional such association, such as a lawyers association, may not offer a plan. So that's the difference. There's no employee-employer relationship among all those lawyers within that professional association. MSA special eligibility rules. The following individuals are not eligible to enroll in a Medicare savings plan. An individual who receives health benefits that cover all or part of the annual deductible under the Medicare Advantage Medicare savings account plan. Examples include, but not limited to, primary health care coverage other than Medicare, Medicare hospice, certain supplemental insurance policies, and retirement health benefits. An individual who is enrolled in a federal employee health benefit plan or is eligible for healthcare benefits through the Veterans Administration may not enroll in a Medicare savings plan. Dual eligible entitled to Medicare and Medicaid cannot have a Medicare savings account. An individual who cannot provide assurances that they will reside in the United States for at least 183 days during the year for which they're making the election cannot have an MSA plan. An individual who has already elected hospice cannot have an MSA plan. Medicare Advantage plans, premiums, and cost sharing. Medicare Advantage plans may charge a premium. If the plan charges a premium, Beneficiaries must generally continue to pay their Part B premium in addition to paying the monthly plan premium. Medicare Advantage plans may also require members to pay a portion of the covered services they receive. This is known as cost sharing. Several types of cost sharing can be a deductible, which is a set amount that the member pays before the plan pays, a copayment, which is a fixed dollar amount per service that the member must pay, for example, $20 for primary care or $400 for each hospital inpatient stay, or it could be a coinsurance, which is a percentage of the costs. And that an example of that is 20% for durable medical equipment. All Medicare Advantage plans must have a maximum out of pocket, known as the MOOP. The maximum out of pocket applies to medical benefits that are covered by Part A and Part B. That means once the member pays the specified amount of cost sharing, the health plan covers 100% of covered medical services for the remainder of that year. And each year, CMS specifies a mandatory MOOP, which the health plans cannot exceed, although many of them will have lower MOOPs than CMS requires. Each plan's MOOP will be specified in its summary of benefits and in its evidence of coverage. The 2026 maximum MOOP, that means that's the largest amount that any plan can have for Medicare Advantage, coordinated care plans, and private fee-for-service plans, is $9,250. Most plans you will see will be lower. PPOs must also have an aggregate MOOP for in-network and out-of-network, and that max for 2026 is $13,900. And you may see lower MOOPs in each of the plans than that. The Medicare Savings Account have a deductible that members must pay, and then the plan pays 100%. So let's look at QMBs. QMBs are the duals. Cost sharing rules apply when they're enrolled in any type of Medicare Advantage plan. QMBs do not have to pay more cost sharing than any minimal copay that would apply under Medicaid, regardless of what the plan requires for other enrollees. All providers, whether or not they're Medicaid participating or in network, are prohibited by law from balance billing QMBs for any Medicare cost sharing amounts, including the amounts under their Medicare Advantage plan. Providers who balance bill are subject to sanctions. Let's do the case study. Mr. Walsh is a qualified QMB. He enrolls in a Medicare Advantage HMO. Mr. Walsh goes to his primary care doctor to receive a Medicare service. The normal copay is $25. The doctor may only collect from Mr. Walsh any minimal cost-sharing allowance under the state Medicaid program, which in Mr. Walsh's case is $2. His doctor may bill the state for the cost sharing, but the whole harmless obligation applies regardless of how much of the cost sharing the state pays. Medicare Advantage plan. Click on the image. Medicare Advantage plans may also cover extra benefits, which you all know at this point, with vision, glasses, hearing aids, dental. Supplemental benefits may be optional or mandatory. Mandatory supplemental benefits are embedded in the Medicare Advantage plan and must be purchased as a part of the plan. They can include reductions in cost sharing for benefits under original Medicare. Optional supplemental benefits may be added to a Medicare Advantage plan at the option of the beneficiary. Beginning in 2026, Medicare Advantage plans are required to send members a mid-year notice of any supplemental benefits that they have not yet accessed. This is new. Remember this. Beginning 2026, Medicare Advantage plans are required to send a mid-year notice of any supplemental benefits that the beneficiary have not accessed. Chronic plans. Primarily health-related benefits to chronically ill enrollees may include such items as decreased cost sharing or supplemental benefits such as home palliative care or transportation to medical appointments. For special supplemental benefits, benefits that are not primarily health related, the latter generally address social determinants of health and are known as special supplemental benefits for the chronically ill or SSBCI. Those benefits may include items such as groceries, meals, beyond a limited basis, pest control, and non-medical transportation. Medicare Advantage plans may implement mechanisms to promote the appropriate utilization of covered services. These mechanisms are known as utilization management. Such mechanisms include requiring a referral or prior authorization to obtain a service. PPOs may not require prior authorization for out-of-network services. Private fee-for-services may not require prior authorization. Non-network Medicare savings account may not require prior authorization. Plans may also implement step therapy for Part B or Part D drugs. Step therapy is, of course, when the plan requires a beneficiary to try less expensive options before stepping up to drugs that cost more. When an enrollee is enrolled in an MA plan after starting a course of treatment, there's a minimum 90-day transition period during which the MA organization may not disrupt or require reauthorization for the active course of treatment for new enrollees, even if they're receiving services from a non-network provider. Medicare Advantage and prescription drugs. An organization offering coordinated care MA plans must offer at least one MA plan with prescription drugs, known as MAPD. Medicare Advantage private fee-for-service plans have the option of offering prescription drug coverage, but are not required to do so. An individual enrolled in a Medicare Advantage private fee-for-service plan that does not include a Part D benefit may enroll in a standalone prescription drug benefit, even if under the same MA contract, the organization does offer another prescription private fee-for-service plan that includes a Part D plan. Medicare Advantage plan, Medicare savings account plans are prohibited from offering prescription drug coverage. So if a person has an MSA, the member must enroll in a standalone prescription drug plan to avoid the penalty. If a beneficiary enrolls in an MA plan that includes Part D prescription drug coverage, the beneficiary can only receive Part D coverage through that plan. If a beneficiary enrolls in a Medicare Advantage plan that is an HMO or a PPO that does not include Part D, the beneficiary cannot have a standalone prescription drug plan. Other types of healthcare plans. There are other types of Medicare health plans which are not Part C or Medicare Advantage. There's Medicare cost plans, PACE plans, which are programs of all-inclusive care for the elderly, and other demonstration plans. Other Medicare health plans include state-specific demonstrations, such as the Minnesota Senior Health Care Options. Medicare cost plans are Medicare health plans that are not Medicare Advantage Part C plans, and they're not original Medicare. Medicare cost plans may offer Part D prescription drug coverage as an optional benefit, but are not required to do so. Medicare cost plans may offer other additional supplemental benefits. Medicare cost plans are available only in certain areas of the United States. In 2025, they were offered in 11 states. An individual may enroll in a cost plan and a prescription drug plan. This applies regardless of whether the cost plan offers Part D coverage. PACE plans, programs of all-inclusive care for the elderly. All Medicare plans for frail elderly individuals certified as needing a nursing home level of care, but still living in the community. These are plans that are available in most states, but tend to have small service area and thus may only be available in a few counties. These are also plans that offer an adult day health center where enrollees can get health care, meals, and other services. This is the plan that includes comprehensive medical and social service delivery systems using an interdisciplinary team approach in the adult day health centers, supplemented by in-home and referral services. The eligibility for a PACE plan, the individual must be age 55, reside in the PACE organization service area, be eligible or certified as eligible for nursing home care by the state, be able to live safely in a community setting at the time of enrollment. Under a PACE plan, there's no deductible or co-payments for any drug services or care provided by the PACE team of healthcare providers. Beneficiaries with Medicaid pay no premiums. Beneficiary with only Medicare pay a monthly premium to cover the long-term care portion of the PACE benefit. Protections, appeals, and grievances. Enrollees in a Medicare Advantage plan, Medicare cost plan, or PACE plan have the right to file complaints, also called grievances, about quality of care, get a decision about healthcare payments or services that they disagree with, or get a review of a plan. I can't move my. Okay, so I think this is one that I can't move until she finishes talking. Wow, we were going along really great too. Let me see, can I go back? If that's the case, we're gonna have, let me see here. It's frozen. My screen is frozen.
Miss Faye, did you try to control alt?
Yes, I did. Okay, we're back to where we were. And I'll share my screen again. Let's see if I can get by her. I may not be able to. And if that's the case, then I don't need to do this because she's going to force you to go along with her speed. Um, Enrollee protections, we talked about grievances. Now we're talking about appeals. The appeal process is used to ask for a review of coverage or payment decisions. So if someone doesn't agree or they feel like a decision has been made that is not fair or correct for their health, they can file an appeal. The appeal in the Medicare Advantage programs, um, all Medicare health plans must provide enrollees with a written description of the appeal process. So it is included in the evidence of coverage that the member receives. It's included in the summary of benefits that the member receives. You may want to mention it. It is also generally covered in the statement of understanding at the end of your applications. Medicare health plans must also include on their websites written procedures for filing appeal and grievances along with phone number so that you know if you can't find it, you go to the carrier's website, look for the phone number, the mailing address for written requests, or any links for any forms if you are helping someone to do an appeal or grievance. Medicare health plans offering a Part D must also provide access via secure website or secure email address on the website for enrollees to quickly request a coverage determination or appeal a decision. They also must require network pharmacies to provide enrollees with a printed notice with the plan's 1-800 number or toll-free number for requesting a coverage determination. For more information, Medicare and You Handbook, which 2026 will probably be out around September. So now we're at the point, is everybody here? Are you still up to doing the practice? Are you ready to go to sleep?
Practice.
Okay, got one practice. Everybody else asleep? Okay, you got to answer these practice questions. So it's up to you. If you don't feel like doing it, just let me know.
I- I'm just driving. I'm listening. So yeah, I
Okay,
guess
well,
that's
I'll
two
read the
goes.
question and then if you want
Okay.
to chime in for one of the answers, then know what you can. How's that?
Okay. Sounds good to me.
Okay, so that's two people. I just want to make sure everybody else has an opportunity to answer a question. If you want to, at least you'll see how the practice test goes if you've never done this before. So I'm going to start the final review, which is the practice test. Attempt this quiz. Okay, the first question reads, Mrs. Lester is age 75 and enjoys a comfortable but not extremely high income level. She wishes to enroll in an MA MSA plan that she heard about from her neighbor. She also wants to have prescription drug coverage since her doctor recently prescribed several expensive medications. Currently, she is enrolled in original Medicare and a standalone Part D plan. How would you advise Mrs. Lester? These are your choices. Mrs. Lester can enroll in an MA MSA plan and remain in her current standalone Part D prescription drug plan. Mrs. Lester is ineligible for an MA MSA plan because she's ineligible for Medicaid due to her income level. Mrs. Lester may enroll in an MA MSA plan, but if she wishes for prescription drug coverage, it must be a MSA PD plan that includes drug coverage. Mrs. Lester may enroll in an MA MSA plan, but if she wishes for prescription drug coverage, she must also enroll in a Medicare supplement plan, Medigap F plan that covers the Medicare Part B deductible and includes drug coverage. What's the correct answer?
A will be the first one.
Everybody agree?
Yes.
So if you think about it, when you read through these answers, you can eliminate some of this because it's just not even applicable. And that's the best way to take these tests. You know that the last one isn't true because who said anything about a Medicare Medigap Plan F? So that's out of the question. So Mrs. Lester may enroll in an MA MSA plan and remain in her current standalone prescription drug plan. Okay, hang on one second, please.